science and stuff, if you're not really paying attention to their history and what you're asking the right questions, you miss a lot of stuff because it's based off of their occupation, prior occupation. Muted it, right?
No, I didn't.
You guys hear me now? I've literally never had anybody complain about how loud I talk. I've sounded this way since I was like 6 years old because I had chronic ear infection and tubes, so the teachers used to make fun of me. So I've sounded like Barry White since I was in elementary school, which is cool. All right, so occupation environmental lung disease. This is very specific on occupations. So you have to talk to your patients, get their histories. If you don't dig into their histories, what they do for a living, and understand what they do for a living, you're going to miss these. So key is history taking, talk to your patients. What are we talking about? So again, key points is occupation and timing. And then very easily, management will always identify it and avoid the offending agent. Easier said than done, right? So if you're a coal miner and I tell you to stop coal mining, what are you going to do? You're like, well, I can't. There's other jobs in West Virginia, Pennsylvania, so I'm going to keep doing it. Maybe I'll wear a respirator, I don't know. Right, military, they can't necessarily change their MOS or change their duty station every time, so you have to figure out. Sometimes you have to do medical boards, sometimes you have to do retention and change their MOS, different tools that you have available to you. So occupational asthma. Presents just like asthma, it's going to have the same signs and symptoms. The key features of this, if you go to work day one, and you have an asthma attack, that is not occupational asthma. Occupational asthma is after weeks and years of exposure. So this is a sensitivity you develop from whatever you're exposed to. It could be just about anything, right? So if you're a maid over time and all you do is dust, initially you may not have a problem. Months after, years after, you start to develop these asthma-like symptoms. So that is key. Is weeks to years, presents just like asthma, and then talk to your patients. Does this worsen? Does it improve, right? I took a week off, I went on vacation, I had no asthma outbreaks. That should be kind of a clue right there to get your spidey senses tingling. High-end suspicion, timing of symptoms is key. One thing you can kind of do to differentiate that is that peak flow measurements, right? Have them do it at home on the weekends, in the evenings when they get home, when they're on vacation versus when they're at work. If they go to work and their peak flow just always suck, that's another point that's kind of pointing you into the direction of occupational asthma. PFTs, just like asthma, the obstructive pattern reversibility. How do you do that reversibility? What's that? So you give them albuterol, right? And then what happens? 12%. 12% increase of what? FEV1, right? That's all we care about reversibility. 12% and greater than 0.2 liters. Again, avoid offending agent, and you're going to treat it. This is where you're going to get OC Health into, because nobody ever really knows how to refer to OC Health, to be honest with you. OC Health is where you're going to go because you're a healthcare employee, you're going to sign into them when you're in process. You'll see them like once a year because you either work like on a high risk or they have to do like your TB screening or something. But you can refer your patients to them if it's specific about their occupation, and there's stuff that they can also utilize, they can order. They have special permissions to order things for patients, so they may be able to get additional respirators. OC Health, I got like half my guys post-work, and the unit wouldn't pay for them. I sent them to OC Health and said it was related. I got TRICARE for their Peltor over-the-ear earmuffs. So there's a bunch of tools that they can do for you. Hypersensitivity pneumonitis, right? So key about this, pneumonitis, right? What is that telling you? It's the alveoli. Itis is inflammation, right? May also hear it called extrinsic allergic alveolitis, which is the fancy term, but for us, hypersensitivity pneumonitis. Key to this is going to be organic proteins that's causing this, right? Maybe delayed from time of exposure. So typically as they get at work, it may not be any problems. 4 to 8 hours after they get home, they start developing these symptoms. You don't need to know this list, but be familiar with it, right? So if I tell you a patient works in some occupation where they're around something that's organic and they're having these symptoms when they get home, this is what it's pointing you to, right? So farmer's lung, right, it's pretty straightforward. I remember when I was at Fort Lewis, anybody here ever been stationed at Fort Lewis or the Court Airfield, right? You ever go down to Olympia? What's in Olympia? A lot of hippies, right? And they also do mushroom farming down there. My cousin-in-law is a mushroom farmer. He has a master's degree in mushrooms. Not the good mushrooms, though, either. It's when you chop up and put on salad. But there was an outbreak of mushroom picker disease from moldy compost down there. So there was like a recall on mushrooms, and then all these mushroom employees got sick. It was a pretty funny article. Couldn't help but laugh at it. But just any organic stuff, right? So sawdust, if they're a lumberjack or work in those industries. And they differentiate between the acute response and the chronic response. So acute response, if you can identify it here, that's best because it prevents it from going into that chronic. Chronic is where it starts looking like ILD, right? What we talked about yesterday. So that first 4 hour, that acute phase, sensitivity, triggering event, 4 to 8 hours post-exposure, usually at night. If they're on night shift, it's usually during the day. You're going to have those just kind of general, generic symptoms, malaise, history, chills, fever, which could be a lot of different things and different diagnosis, but the key is that triggering, and it worsens when they get home after about 4 to 8 hours. Nondescript findings on there, you will see increased WBCs with neutrophilia on the CBC. Now we go to that chronic phase, right? This is where they start looking a lot sicker. Slowly progressive dyspnea, anorexia, weight loss. What are some things for differential diagnosis that could be? The patient just came up with those.
Emphysema.
Cancer, what else? Emphysema, right? They start getting that wasting disorder. What else? TB. Could TB cause that? Right? HIV, could that cause that? Yeah, so there's a lot of different things. When you work these patients up, you may get a chest x-ray. What do you see on chest x-ray with ILD? What kind of, no, that's a CT. Chest x-ray is what? Diffuse, but what's that term we talked about yesterday? Ground glass. Ground glass, right? So chest x-ray, you may see ground glass. And your spidey sense start going off. You're thinking some type of fibrosis, so you get a CT. And then you see that honeycombing, right? You get a PFT, right? Their FECs decrease, lower limits of normal. Then we're thinking restrictive, fibrosis. They get that bronchoscopy, confirmed diagnosis. Confirmed diagnosis, but does it tell you the underlying etiology? No, so this is one of those times where you may be able to actually diagnose ILD and figure out the etiologies based off their occupation and what they're presenting with. Treatment, again, avoid exposure, ruin their whole life, help them change their job that they've been working at for 30 years, right? High-dose steroids. But reality is that when we talk about avoid exposure, they may not have to change their jobs. There are laws in place in the United States, at least for now, that allows them to maybe be able to work to a different position in that company under laws that OSHA provides. And then these are always going to go to pulmonology. Everything we've talked about today are going to get referrals to pulmonary. Again, those that ground glass appearance on chest x-ray, and then that honeycombing on CT. Toxic lung injury, bronchiolitis, obliterans. So this is what I was talking about, that popcorn lung, right? Everybody heard about that too, with like the commercials with vaping. Get your kids to stop vaping, they'll get popcorn lung. So popcorn lung is a physical characteristic finding, right? It's nothing like that, but it goes back to, in I think 2020, they found about 200 employees at this company who started developing these symptoms of fibrosis. And what it was, not fibrosis, but these symptoms similar to this, they started finding that it was that buttery flavor that's in microwavable popcorn, that chemical, they were inhaling it day in and day out. They started developing this. So This could be vaping, this could be any toxin. Less important that you identify the toxin that's doing it, which sometimes that may be beneficial, but more so that there is some toxin that's causing this. Also here, bronchiolitis obliterans paired in RSV for pediatric patients. It's an inflammatory process of the small bronchioles, right, so close to the alveoli. More destructive than RSV. So if you find these patients late, damage is done. It's not really reversible, so you need to identify it sooner than later. Diagnosis depends heavily on preceding exposure history. So talk to them, you may have to do a quick Google. If they mention that they work at so-and-so, you've never heard of it, you don't know what that toxin is, what everything is, call poison control. They have that 1-800 number you can consult. And what they'll do is they'll actually go through it, look up all the data, and tell you, yes, this is at risk for that, and you can use that for your patient. Slowly progressive cough and dyspnea over weeks to months. Again, there are work that expose this, maybe NIOSH and OSHA are not doing their jobs, nobody's enforcing anything. They're not wearing respirators. Start getting these, and they start getting easily fatigued, tachypnea, crackles, possible wheezing. It's a obstructive pattern, but it's not reversible. So it means you give them albuterol after you get that PFT. There's no reduction in their FEV1. Chest X-ray, usually minimal findings. You get your chest X-ray PFT, then you're saying, I still don't know. You can go to CT. You may see some alveolar damage in smaller bronchioles, better than chest X-ray. Maybe nondescript where they say there's damage, but it's not conclusive of anything. Tissue biopsy, again, via bronch is going to be your definitive diagnosis. Without further exposure, consult with pulmonology. And like I said, extremely difficult to treat. Once the damage is done, there's not any reversal for it. All right, smoke inhalation. So I spent 3 years working at the Army burn unit here during the peak of the wars, 06, 08. We were doing a lot of evacuations, a lot of treatment. At the time, we were the busiest burn unit in the nation. We were seeing a lot of these injuries, especially 2 to 3 years after the initial invasion of Iraq and Afghanistan. Why do you think that was? We started seeing more and more. The IEDs, so was our vehicles, right? So what was these hallmark diseases that we saw in Iraq and Afghanistan, global war and terrorism, traumatic brain injuries, smoke pit exposure, stuff like this. So as the vehicles and technology got better, people would survive the initial blast. They would get stuck in their vehicles, they would get inhalation injuries, cyanide poisoning, things along those lines. So you will see these, you'll see these, guy a few years ago here died of inhalation injury. I guess it's kind of funny, but it's sad. He was too obese for them to get him out of his car, so he wasn't actually on fire, but he died from inhalation injuries from the smoke inside the car because they couldn't get him out and extract him. So enclosed space is what we're concerned about primarily. So the first part of that injury pattern is going to be thermal injury. That's that superheated smoke, right? The actual heat that's going in there is going to cause that airway edema obstruction. We'll talk more about that. Well, what kind of signs and symptoms do you think we would see with that? Yeah, carbonaceous secretions. Those secretions they spit out, it's kind of black. Already has little flakes in it around their mouth. So what else do you say? Yeah, singed facial hair and everything else. That also looks like my uncle at 4th of July when he's starting the grill, right? He puts a bunch of starter fluid on there, hits him, and he comes in the house, right? Strider. Then as we progress, impaired oxygenation. 2 primary mechanisms we're going to talk about is carbon monoxide poisoning, right? That smoke generates, it's going to create carbon monoxide. Hemoglobin has a higher affinity for it, so it prefers carbon monoxide versus over oxygen when it has a choice. Cyanide poisoning, what's causing that cyanide poisoning? Yeah, plastics, textiles, things in those vehicles or things in the house you're going to see. And then chemical injuries, these are typically a little bit later onset, secondary to some of these previous injuries. And that's where we're going to start to see actual tissue damage to the alveoli, the proximal bronchioles. As it goes into, then this is very high likelihood and starts proceeding into ARDS, acute respiratory distress syndrome, which we'll talk more about in the class. So thermal injury of upper airways, what we're seeing in these pictures. So this is like upon admission, and what you can see over here. Very erythematous. It's swollen right here. If you compare this to this last picture, right? See, this is not as swollen. This is visibly swollen going down there. You start to see some of this. The tracheal rings are a little bit more pronounced on here. You start seeing some inflammation. And as that tissue starts dying off, sloughing off right here, where's this going to go? It's going to go down, right? Their cilia are destroyed from that heat. So they can't actually, they have no mucus elevator, they're not able to clear the secretions right here. So this stuff keeps sloughing off and it keeps going down. And then it actually starts sloughing off pretty quickly. And then this is what we're going to see probably like day 2 to 3, maybe a little bit later. But you can see this very kind of waxy white color right here. That's thermal injuries to the tracheal ring, to the bronchi. Start seeing how it's more pronounced. It doesn't look very healthy. Right, so all that stuff went down their lungs, so you have to be aggressive with getting it out. Respiratory stridor, they can't clear their secretions. Respiratory failure is possible. High risk for hearts. What we can do, especially initially, humidify supplemental oxygen. So you can supplement, you can humidify any oxygen device, nasal cannula. They also have masks that you can humidify. There's a number of tools available for you. You can provide humidification if you have to take their airway and intubate them. We wanted to elevate their head of the bed, helps promote secretions, and as that airway starts tightening up, it may make it a little bit easier to breathe for them. Talking about nebulized epinephrine right here. So it's actually racemic epi. So you don't want to take that cardiac epi, throw it in a nebulizer and do it. You're going to cause some damage to your patient. So racemic epi is a little bit different. It's epi-L, epi-D combined. That'll help with some of that stridor. We sometimes give it to patients post-intubation or when we extubate them to help with some of that stridor afterwards. Closely monitor oxygenation status. So what do we think SpO2 is going to be at this point if we have a known inhalation injury? High or low? Low? Most likely going to be high. We'll talk about it here in a second. That's kind of a false positive unless you have specialty equipment. But be ready, right? Especially if you're pre-hospital, austere environment, or community hospital, or somewhere along that line, you want to intubate these patients sooner than later. My kind of rule of thumb is if I have to think about something 2 or 3 times, probably my mind telling me I need to do it. Because if you wait, vocal cords will start swelling, becoming very difficult to intubate. Then you may have to trach or trach if you wait too long. Now, secondary to that is all that smoke, everything, carbon monoxide poisoning. So we talked about it was hemoglobin has a higher affinity for carbon monoxide than it does oxygen. So that's going to give you a false reading. So your pulse ox, all it's detecting is hemoglobin saturation. So it'll say 100, and it's kind of giving you a false positive, right? You're like, cool, it's 100. Patient looks like crap. They're not oxygenating or they're not ventilating very well. They look like they're in distress, but the pulse ox is saying 100. So unless we have a CO oximetry, right, which you're probably not going to have, most small places, big places like BAMC or academic hospitals will have those. But regardless, we want to start them on oxygen. So we see the signs and symptoms, right? Severe headaches, ultra-mental status, seizures, that cherry red skin that everybody always talks about, and like synthetic whiskey, EMT, like basic medical training, it's very rare. Less than 20% of patients are going to have that true finding. Why would they have metabolic acidosis? Right, so Rome, what's acidosis? What's the pH doing? Going down or going up? Down. Going down. So what does that mean the pH is doing? Yep. CO2 is going up. It's climbing, so they're becoming hypercapnic. Mediate high flow. So this is where you want to give them 100% non-rebreather mask. What's the flow rate for 100% non-rebreather mask? 10 to 15 liters per minute. We're going to talk about oxygen therapy in another class. But 10 to 15 liters is for a non-rebreather. You want to get it cranked up so that they're blowing that off. Other things you can do, if you don't have a non-rebreather, any oxygen source, venturi mask, simple mask, even a nasal cannula. If you're at a big city like this, BAMC has one now finally, it's a hyperbaric chamber. That'll actually reduce it very significantly, very quickly, in about half the time that this will. If you gave them nothing and they survived it, it would be probably at 1 to 2 hours as they off-gas that CO2 and they start to normalize. but they may not make it that long. Non-rebreather is going to cut that in half. And then hyperbaric would cut that even further to get it displaced quicker. Cyanide poisoning, this is one of those things a lot of people don't consider, right? They do that, they give them 100% oxygen, patients confused, and they have carbon monoxide poisoning. So when you think about cyanide poisoning is same mechanism, same kind of vignette about the patient. They are in a confined space, smoke inhalation. Concern that you've given them 100% oxygen, and you're proceeding forward and it's not improving, we're going to think cyanide poisoning. So that is, talked about that, it's production of plastic and textile combustion. Cyanide binds to the cells, right? They can't actually use it, so it results in this functional cellular hypoxia. So functional meaning you have the oxygen, you just can't use it, right? You're flushing the body with all this oxygen and there's cells because the cyanide's binding to it, blocking it. You just can't use it, and that's called that functional hypoxia. Additionally, with that, as those cells don't have oxygen, they're going to start going anaerobic, start breaking down. It's going to increase their lactic acidosis, right? Lactic acid, what's that going to do to their ABG? It's going to be what kind now at this point? Be a metabolic acidosis, right? Because this is non-respiratory. So they have kind of two different mechanisms going on now affecting the pH. And again, the patient's not improving because they can't utilize that oxygen, right? They may have some more pronounced symptoms in comparison to carbon monoxide poisoning, seizures, coma, cardiovascular collapse, death. Anybody ever actually use these cyanide kits? Yeah, I've had them on like my things when we do our layouts, but I've never used them. So all it is a vitamin B12 precursor, that hydroxylamine. But essentially all that does is it binds to the cyanide and then allows the patient to urinate it out, right? So some places you go, if you look at their flow charts, we have one right here, they may actually have that in there as prophylactically. So it's one thing to consider that, do that. You may be working at an ER in your phase 2 where that's part of their flow chart or treatment is you prophylactically give that if there's concern about cyanide poisoning. Then find cyanide in almonds, right? That's just everything we just talked about. Now, chemical injury to the lower airway. So I want you to think all that stuff is sloughing off, all those toxins, all that burned tissue, everything is coming down and it's collapsing and going down to the lower lobes and starting to fill those alveoli. You also have chemical byproducts of combustion, right? About 20 years ago in South Carolina, there was that train that went off the trails that was carrying ammonia. Remember that one? So after that, I was working in pulmonary research. We got a grant from a government agency to study that too. How to weaponize ammonia. It's actually a lot harder than we thought it would. We had PhDs, MDs, everybody working on it. We couldn't develop how to weaponize it. But guarantee you, if you go to a trailer park in Georgia, some guy can show you how to do it. Like, shit, man, that's what you're trying to do? I got you, bro. Let me show you. But the concern with that, right? So that smoke injury, you don't know what was in that smoke. There could be other toxics that was burning up that was causing in there. They're a high risk for ARDS, right? So typically the timeline is you get that patient, you initially stabilize them, you may intubate them, you put them on a ventilator, and then about 24, 48 hours, things just start going sideways. They start getting all this flash edema in their lungs, can't oxygenate them, not responding to any diuretics, it's not cardiac or cardiogenic, that could be ARDS. But almost always, if they do not develop ARDS, they're going to develop some type of pneumonia, some type of infection within 5 to 7 days. So, well, we'd say this is a nosocomial infection if it's 5 to 7 days, or hospital acquired. Hospital acquired or community acquired. Technically, it's a hospital acquired, right? But this is where you're going to get infectious disease involved. Say, hey, this doesn't. The injury was initially, but it developed 5 to 7 days. It's technically hospital-acquired pneumonia or nosocomial, but let infectious disease kind of drive that train and guide you on what that is. You're going to get sputum samples and everything else to treat this, to figure out what bug it is. Symptoms variable because we don't know what was actually exposed or what caused it or what was in that smoke. We don't know what was burned. This is an example of ARDS developing. So this is probably upon admission. We start to see some of this in the lower lobes. right? It's progressing, starts consolidating, and by the end of it, we're seeing both the lungs. And that's basically the lungs are filling up with fluid because of increased permeability between the alveolar and the capillaries, and fluid just leaking out into the lungs, and it's not responding to anything. So if you think about that fluid overload, right? To keep me tachycardia, they're breathing faster, they're still trying to oxygenate, trying to blow off. But despite the work of breathing, whatever you're throwing at them, the hypoxia is going to continue to worsen. They're going to continue to go downhill until you figure out what's underlying it. Diffuse wheezing, because their lungs are wet. What else would you hear if like alveoli are wet and surfactant's not there and they're like kind of snapping open? You may hear crackles initially. Rapid onset, supplemental O2. This will make more sense once we go over ARDS. I think it's tomorrow. It'll tie into this a little bit more. All right, pneumoconiosis. So, this is a restrictive disorder that you're going to see on PFTs, right? There's 3 subsets of it that we're going to talk about. There's a lot of different ones. But what's causing this is some type of irritant, some type of inhalation of organic or non-organic dust or fine fibers. Consider occupational disease because that's most likely where we're going to see these 3. Causes inflammation and fibrosis causing irreversible lung disease. So basically a subset of ILD, right? Remember, the restrictive pattern is going to be smaller volumes and it's going to be peaked. It has an ice cream soup out of it. What is it? Obstructive, right? Alc Health PPE compliance. This really didn't start to gain traction in the United States till late 60s when they passed the OSHA Act, right? Everybody kind of complains about OSHA, but as you go through this, I love OSHA, right? I'm big into genealogy. My family's from central Pennsylvania. My father's side, they're all coal miners. Well, they were coal miners. As I started getting into genealogy stuff, I started seeing a trend. About 75% of the men didn't make it to be elderly. They died from 2 reasons. Coal miner's lung, or they died from accidents, cave-ins, getting hit in the head, just poor work environment. So that created in 1970, then they created NIOSH and OSHA. So OSHA, if you think about it, is the body that kind of actually enforces the rules. They actually go to the sites, cite people, bring them to court, everything else. NIOSH is the CDC body of it that does the research and provides the guidelines and kind of the guidance to OSHA to what they should enforce and what should be going on in these work facilities. So coal worker's lung, black lung disease, right? So similar to TB, they ingest some foreign substance, being that coal dust. The macrophages do what they do. They engulf it in the upper lobes primarily, especially in the beginning. Slow progression to fibrosis. The smaller sites, as they inhale that coal dust, they get these little small nodules, and over time, those small nodules start kind of combining together, creating bigger and bigger. So initially, these patients really aren't symptomatic. They resolve or they kind of continue to work. They're hardworking people. Asymptomatic till very late. Unfortunately, if you're not screening these people and engage with them with OSHA and NIOSH, then you're going to start to see that by the time it's late stage, there's not really a whole lot you can do. This is what you're seeing, healthy lungs, and then after 30 years. So really specifically, this is without filters or any type of work environment. This is what their lungs look like. Again, there's Zoolander. So you see those diffuse, right? Upper lobes up here. Wish I had a better picture of that kind of progression, but eventually over time, this is going to start consolidating and start taking over all of the lungs as they go. You're going to start to see more and more of this, but it begins in the beginning. So remember, 2 to 5 millimeter opacity is prominent in the upper lung fields. See upper lung fields as opacities, I want you to think coal miner disease. So, same disease set, just a different subtypes. Silicosis, mining, stone cutting, cement manufacturing. When I was in, where was it? Central African Republic or DRC, we actually had to go to a cobalt mine for work. That was probably one of the scariest, saddest things I've ever seen. It was something like from hundreds of years ago, just people working in these fields with no type of protection, damn near naked because it was so hot, just wearing like underwear or shorts, frequent rollovers, frequent landslides, people dying, but just all that silica that's in the air because they're just destroying rocks and just basically smoke and dust and everything else going up there. So we're going to see in about 20, 30 years of those people, everybody's going to start developing this stuff. So when they talk about rare earth metals or mining for it, you don't have those work environments or those protections in place. This can affect surrounding places too. So it won't just be the workers, it'll be surrounding communities that'll start getting exposed to this stuff. But what's hallmark about this eggshell calcification? Calcification of the hilar lymph nodes. It's very unique to this disease pattern, right? So the chest x-ray and the radiologist puts eggshell calcifications or calcification of hilar lymph nodes that want you to think silicosis, right? It's very similar to coal miner disease, the same kind of disease pattern in the sense that the patient inhales this fine dust with the silica in it. Macrophages take it up. They hold on to it, and it starts forming these small sites. They start forming up, and they become bigger and bigger masses as they go. And over time, that's going to lead to severe lung impairment, right? So initially, they may be asymptomatic or kind of vague symptoms, but as they progress, 10, 20, 30 years, now it's actually impeding their pulmonary function. They can't breathe, they can't oxygenate or ventilate. Same things as far as they're asymptomatic until very late. Unique about them, though, too, is if you diagnose one of these patients, you have to have high index suspicion for TB. They're at increased risk for it because it destroys those alveolar macrophages, right? So preventing other infections. So these patients, you do routine chest x-ray, PPD screening for TB. So if you send them to OC Health, Public Health, a lot of time that becomes part of their treatment kit. They're set that every year they're going to come in for repeat exam and get routine chest x-rays and PPDs. So silicosis, be concerned about TB because they're increased risk because that alveolar macrophages are destroyed. Again, you see, nobody wants to wear a mask until they get these. You see these little eggshells right here? The hilar lymph nodes. And as they start to progress out, they're going to start going laterally. And you start developing here, and you're going to start to see it take over. So this patient on the left, very likely asymptomatic, right? They may have some mild symptoms. The patient on the right, be very, very symptomatic. What kind of PFTs would we see with these? Restricted. If they had an underlying disease, they're a smoker, or they have asthma, what kind of PFT might we see? Mixed, right? So that would mean restricted, their FVC is decreased, and then what else would be decreased or concerned about obstruction? So be that FEV1, FVC ratio would also be decreased. Asbestos, everybody's heard about this one, right? The commercials. Anybody here ever been exposed to asbestos? Right now you are, I promise you. Right? The number of IPAP students that have threatened to burn down this building is still standing. Right? You ain't burn this building down. So, one of the few things that, like, my prized possessions from the military was my medics got it for me at Fort Lewis. So I had a grade aid station when I was in a field artillery battalion. It was about a quarter mile from the battalion headquarters and from all the soldiers. So just far enough away that nobody could drop in, but it was close enough if I needed to go talk to somebody, I could walk down there. It was beautiful, I loved it. Well, they said, hey, we're gonna redo your building and turn it into like the brigade aid station. You guys are gonna move across to the trailers across the street. So literally the day we moved out, they put caution tape all around it, put a big giant sign that says, do not go in asbestos. I worked in that building for like 2 years. So the day I left that unit, my medics printed up that picture, signed it, framed it for me. One of my prized possessions. So when we think about kind of the classic example or question, shipyards, construction, pipe fitters, insulators, people doing deconstruction or tearing down buildings is another one, right? Have you ever seen The Sopranos? The whole thing with the mob is they're undercutting the actual good companies because they're just hiring random people, criminals or ex-convicts or immigrants to do this work without any type of OSHA protection or anything. to get rid of all this stuff. Again, think construction, shipyards. Used widely as a heat insulator, banned in 1989. So again, this building built long before 1989. Also used in vinyl flooring, so old houses, right, as they're tearing up the houses, that's an increased risk because now they're starting to deconstruct some of those products. And just like the other ones, macrophages, but what's unique about asbestos, it goes to the pleura, right? So the unique finding on the chest x-ray is pleural calcifications. Asymptomatic until very late. Typically this is an exposure one, but if you get a large exposure at once, you're at risk, but it's more so combined exposure to this, so if it's long term, then your risk goes up higher. But you're going to see this linear streaking, honeycombing, just like these other fibrotic diseases, but what's unique about this one is pleural calcifications. We'll talk about that a little bit more. So you're going to see honeycombing and pleural plaques on the chest CT. Mesothelioma, right? There's that lawsuit that's always going on. Were you exposed to this from the years 1981 to 19 blah, blah, blah? What's unique about this, mesothelioma is almost always correlated with asbestos, right? 80% of cases. So if you have a cancer patient, most likely this is the underlying cause that caused that. And then here, on the bottom left actually has the best example of those pleural calcifications you see in the lower lobe. It's very unique, right? It's almost the out shape of that lung. It's a sharp angle. So this is a hallmark of this disorder. You see it a little bit on here. It's a little bit more difficult to see on the CT, but you can see some of the calcifications around here. But you see all that honeycombing and some of those linear streaks right here. Sides. A little bit less on here. So linear streaking. All right, any questions? Cool. All right. You guys want to stay later today? So we can either go strong tomorrow, strong Friday morning, or we'll be done.
Strong Friday morning.
I want to keep going. All right, let's take 5 minutes.
Well, it's not maybe tomorrow. We don't have tomorrow. Tomorrow is the 52 morning tomorrow. That's canceled. It's the 2 point. Get canceled. I won't do it. So now just 2 mornings. We're supposed to do a big ball tomorrow. Well, she's not gonna come down and everything. It's gonna be after lunch. It doesn't matter. Oh, I have no idea. I think it's still hurt. I don't think he's doing anything harmful. Oh, yeah, y'all didn't see that? That's it.
That's great. I was like,
I looked good when I was 15. I mean, if it was me and you, one of the last well, this one, 38. I'm going to get the small one after. What's happening is respiratory failure, stress, how having
Another way.
Do you know how every we had
It's a winter.
every year it's just based on the results. Like you have to give something wood, something glass, something silver.
yeah, like she always has like on the farm the day that they don't have farm. Oh yeah. Twice no, because he teaches so I think and then like some of them are shit for us, but probably getting ready to purchase certain items. I don't think there's anything fun.
Like, I'm looking for $80 shoe and you're looking for your standards of your mind stuff.
Well, that's, I don't think she's going to be teaching the mega farmer semester. I think he's better. She was going to be accepted. I don't think you're being because he's still teaching GI. So far, yeah. All fun. I don't know why. Like, she helps me the best she can. But she's actively trying to help me. Trying to like walk her through that. She was all like, I might figure it out. Figure it out. She knows what she's doing, but like, she's actually trying to help us. So that's yeah.
Alright, you guys, alright? So we're gonna knock out PE and a few other little vascular disorders. PE is gonna get beat to death, and ER is gonna get talked to by me in hematology, and probably, I think, cardiology probably talks to you a little bit about PEs and DVTs. So it's gonna get beat to death by you, but if you can identify it, you can actually save lives, because most of these do not get identified. So the patient dies and they find them on the autopsy. Right, so we talked about this, right? Blood comes deoxygenated from the right ventricle. Where does it go? Pulmonary artery or vein? Pulmonary artery goes in there, exchanges that oxygen for CO2, CO2 to oxygen, right? And then where does it go from the lungs? Pulmonary vein, and where does it go from the pulmonary vein to what? The left ventricle, right? So it's key to understand that and how this is going to play into their cardiopulmonary system. So what we talk about, mostly PE, and then a little bit pulmonary hypertension, core pulmonal, and then pulmonary vasculitis. So PE, very simply, it's a thrombus of some sort that is blocking obstruction of the blood vessel in the lungs, right? So a number of things that could be causing it, but third leading cause of death in hospital patients, right? Hospitals are bad, right? You don't want to stay in hospitals. That's why I always like when patients are like, I want to stay an extra day. I'm like, no, you really don't. Like if I show you statistics, you wouldn't want to be here an extra day. Get them out of there. The longer they stay in there, the higher risk they go for VTE, venous thrombus, right? Injuries, emboli, infections, all that good stuff. But complication of thrombus formation with a deep venous circulation, does it have to be a blood clot? It could be a number of things, right? So it's just an emboli. 50% are asymptomatic. What's the number one most reliable symptom that you'll see in a PE? Is that? Kind of all over the place. Just keep in mind what I'm saying, and it'll make more sense. You're going to see it again. So thrombus is the most common, right? Most proximal lower extremity DVT will be the majority of those. Easy way to do that, ultrasound, right? So in your senior semester, you're going to be shown how to do an ultrasound. You're actually going to demonstrate it to us. You'll be graded. It's one of your labs. It's a class. for ruling out DVT or extremities. But air, right? They always talked about like flushing out the air before you put in the line is like a little tiny bubble. When you give medications, is that going to cause this? No, you got to put like a big tubey syringe on there and like get them in there, right? It's not going to be a tiny little bubble when you're administering some medication. Or when they're doing neurosurgery using certain tools. Septic emboli, effective endocarditis, part of that breaks off in the heart and then travels into the pulmonary vasculature. Tumor cells, right? Some of those tumor cells can break off. We'll talk more about the in your pulmonary neoplasms class about how that kind of plays in there. And we'll talk more in oncology your senior semester. Fat, long bone fracture, they have a femur fracture that could risk to cause a PE. Foreign bodies, IV drug users, right? They just use whatever needle they have, spoon, bottle top, they inject it. They also have a risk for endocarditis. Parasitic eggs. All right, so I promise you in your phase 2, you're going to get pimped on this by somebody in one of your rotations, whether it's ER, general surgery, internal medicine, they're going to ask you what is Burko's triad, right? So what I want you to get past that is understanding and kind of putting that together when you're talking to a patient or looking at a patient, right? Because the patient's not going to say, I have this, right? They're not going to say, I have stasis of the blood, or I have a vessel wall injury. They're not going to put that stuff together. You kind of have to understand it. So right? Coagulability. So what is causing that, right? What are some things besides cancer, thrombophilia, inflammatory disease? What's that? What?
Bed rest.
Smoking,
Bed rest.
pregnancy. What about some medications? TXA. Hopefully nobody's abusing TXA. Like, come on, I need that. You can't buy TXA over the counter in Japan, though. Yeah, they sell it for women. I bought a bottle of it. I used to have it. It was TXA and Japanese writing. It's tablets, not injectable. What about contraceptives? Yeah, OCPs, is that a risk for that, right? TRT, right? Everybody loves TRT, right? They're 20 years old and they have great testosterone, but they're like, I need a little bit more, right? And they abuse it. All those things that be causes. So talk to your patient, stasis of blood. What are we thinking for that? Classic is a flight, right? Patient comes off a long flight, they're elderly, they had surgery the week before. They have some unknown clotting disorder, and that's the history. What else? Post-surgery, right? We'll show a few pictures, but this guy, he just had a surgery, right? What do we usually put on their legs? Compression stockings or those little pneumatic devices that help to kind of flex the muscle. So just talk about that with your patients. They've been bedridden because they've been sick with something else, or they've been in a hospital for prolonged periods. They're increased risk. And then vessel wall injury, right? Surgery, chemical irritant, inflammation. What else? The trauma, right? They got in a car accident. They got hit on their leg, and they're taking some days off, hiding out the house. They had a bad parachute and their parachute landing, and their legs all mangled up. All those things kind of tie together. So it doesn't just have to be like what I'm saying here. Put it together, and if it makes sense. So obviously that thrombi is blocking the vasculature on there. What we instinctively do is the vasculature around there also causes vasoconstriction, which then further impedes backflow, which is putting further strain on the pulmonary vasculature, which is going to lead to what? What's it going to put strain on? If I increase the pulmonary pressure of that vasculature, it's just going to put stress on their heart, right? So further decreases blood, dead space, air can't get to the alveoli. Air gets to the alveoli, but it can't be absorbed. What you're seeing right here, so bottom left, this is the infarct damage, the clot. So this is going to back up the blood. It's going to start putting more pressure on the heart. The heart has to work harder, right? If you remember your right ventricle, is it as strong as your left ventricle? No. So an unstable patient, we're going to be talking predominantly about stable patients hemodynamically. Hemodynamically unstable, they're going to be talking more about that in ER, your senior semester with you. But in a hemodynamically unstable patient, the leading cause of death is right ventricular failure, right? So that right ventricle is not designed to do that much work. It's getting backup of resistance, starts trying to pump harder to get the blood into the lungs, it can't do it, and then you ultimately have this acute failure. And that'll make more sense when we talk about pulmonary hypertension and those other disorders of the core pulmonal. VQ mismatch, right? What's a test that we can do? Talk about VQ scan, right? So this is the same concept. So ventilation equals perfusion equals quantity, right? So they inhale. So that ventilation matches the Q, which is the perfusion, right? So this image is showing you on the left, right? This one that says 2.5, 2.5, it's even on both lungs. This other picture right here, what we're seeing is a clot. So now they're still ventilating the equal to both sides, but they're not perfusing the same, which means your body's going to start breathing faster. Your heart rate's going to go up because it's still trying to meet the oxygen demands of the tissues, but it can't because that one lung can't keep up with that, right? So ultimately it's hypoxemia. The immediate response is breathe faster to try to meet that demand, but it's not working because one lung is shut down now. Patient history, right? So we can use Wells criteria, which we'll talk more about. So there's Wells criteria for PE and there's a Wells criteria for DVT. They're very similar, but the scoring is slightly different. We're going to be talking about Wells criteria for PE, pulmonary embolism. So lower extremity trauma or injury, right? We talked about that. Did they have surgery? Did they get in a car accident? Did they break their leg? Did they sprain? A number of different things. Significant, always ask that question. Have you ever had this prior DVT or PE and they may not understand that, so you may have to put in different terms. Have you ever had a blood clotting disorder? Did you ever anybody ever tell you your blood's thick? Did anybody ever say you need to take an aspirin? A number of ways you can ask that to get the same result. Recent immobilization, were you in the hospital? Were you recently laid up at home because you weren't feeling well? Or you couldn't get out of bed? Recent surgeries, increased risk. OCPs or HRT, hormone replacement therapy, right? So it'd be postmenopausal woman that's on hormone replacement therapy, could be a guy, right? When you guys graduate here, you're going to start getting hit up by job recruiters and the amount of testosterone replacement clinics that are calling me to try to get a work for them. So I'm like, no, man, I don't want to give testosterone for a 20-year-old who gets sued the next week. I'm cool. But there's a ton of those clinics becoming more and more available. Pregnant or postpartum, increase for these two as well. Cancer. And the physical exam is going to vary based off the size of it, right? Smaller emboli will be less symptomatic, or especially if they have any pre-existing cardiopulmonary status, right? So if they're already in cardiac failure, congestive heart failure, they're more likely going to be symptomatic. And when I was talking about the most reliable, most common is tachypnea. But for testing purposes, dyspnea, chest pain with inspiration, tachypnea, that classic triad. So anytime you have somebody comes into the ER with acute dyspnea, right, acute shortness of breath, PE should be like, boom, like number 1, number 2 on your differential diagnosis, right? Like that's very concerning. Like my start sweating, my heart races when I hear that in the ER or I see that in the differential diagnosis or coming up on the screen, that acute onset dyspnea. For me, I automatically start thinking PE. I start thinking about worst case scenarios. And almost all these patients, the greater 90%, they're going to have tachypnea, right? So if they have acute onset dyspnea and the tachypnea associated with it, I'm thinking PE until proven otherwise. What else could it be that's life-threatening? What's that? MI? What else? What's that? Yeah, pneumothorax, right? We just talked about that. That's another one that would cause these symptoms. All 3 of those can kill you pretty quickly, right? So we want to get a workup very quickly on these patients. These other ones, they start kind of going down, right? Dyspnea is still most common, but tachypnea is going to be your most reliable sign. Pain on inspiration, likelihood is a little bit less, but still pretty high. Cough, almost I've never had a patient or seen a patient that's coughing up blood with PE. Not to say it doesn't happen. Wheezing, possibly. tachycardia very high. Then what would be lower extremity signs of a DVT? Pain, swelling, unilateral, right? That calf is just giant, red, swollen, very tender. They don't have a great explanation for it. As a brand new PA, I think it was probably like my first or second day of sick call. First sergeant came in, he had calf pain. I just had one of those moments. I was like, ah, shit, this guy's having a DVT. Meanwhile, he literally just got done running 5 miles. So was that Virgo's triad? No, like probably the only risk factor that guy had was a smoker. But in my mind, I was like, he's having a DVT right now. So I started doing this workup, and then the brigade senior PA kind of pulled me off the side. He's like, hey, I don't want to say it in front of the patient, but you're 100% wrong. You know that, right? I was like, no, he's got a DVT. He's like, no, man, guy's probably hungover, dehydrated, probably got a calf sprain, or he's having muscle spasm right now. Luckily, he stopped me, and so it literally was that. But I was thinking DVT, and I was working it up and getting ready to call the ER and make an ass out of myself. All right, so it's labs. As we start working out, you're going to hear D-dimer a lot, right? D-dimer is a good test, right? It's a natural process if you have a clot, but it can also be other things, right? So if the D-dimer is positive, does that mean that they're having DVT or PE? No. If it's negative, is that a high likelihood that you ruled it out? Yeah. So if they're a high-risk patient, right, they have that classic triad, and then they match Virgo's triads, you do your Wells criteria, they're going to be very high score. We may not have to do a D-dimer, we may go straight to a CTA in certain circumstances. But D-dimer is very important in PEs. We'll talk about a little bit more about that. What about troponin and BNP? What will we use those for? MI, what else? So these are cardiac markers, right? So troponin, that'd be MI, or myocardial infarction, something like that, ischemia. What would BNP be more appropriate for? Heart failure, right? So more of a long-term patient, or some secondary cause, but they could also help us rule that out too as well. Respiratory alkalosis. So what would that look like on a ABG? pH would be high or low? pH would be high, and then what would be going with their CO2? Below, so they're blowing off all that CO2, respiratory alkalosis. ECG, 70% have sinus tach, right? So, see sinus tachia, they're dyspneic, they're having chest pain, high threadle, I'm still thinking PE. You also hear about this S1Q3T3. I've seen this, we have to mention it, right? It's not that common, it's less than 10%, but you're gonna see it on your, probably on your pants, you'll see it on your panries. They always, for some reason, love to throw that one in there, but realistically, you're gonna see sinus tach, much more common of a finding with PE. So then what this little box out here is telling you, why would an EKG be more, why would you see it more likely on an EKG versus physical exam findings? EKG is more sensitive, right, than my finger of putting it on the pulse and trying to examine a patient, right? It's the same thing with like a DRE versus an ultrasound. My finger is more accurate as that ultrasound if I'm trying to measure somebody's prostate. Like I can't say, I'm like, yep, that's 2 centimeters or not. The EKG is going to be a lot more accurate. It's providing real time. You may not have great tactile sensation with your fingertips to be able to feel that. But that's what that S1Q3T3. There will not be any EKGs on this test, but understand what that is telling you. So lead 1, that large S wave, right? Down here. Q3 and lead 3, so that Q wave, and that T wave inversion. Imaging and special studies. Chest x-ray, never a wrong decision in the first case. If you're not 100% sure what's going on, it's quick, it's reliable. You can get it done while they're still setting up your patient. Radiology will come there to bedside. Rules on other causes is not great for ruling in for PE. There are some findings on there that you may find, but I wouldn't hang my hat on them and say, yeah, you're having a PE based off of these. Because the findings that you would see on a chest x-ray are very late findings. Most likely your patient's already heading down the drain if you're not addressing it sooner than later. Study of choice is going to be CTA or CTPA, pulmonary angiography. Only time we're not going to do that is what? What kind of patients wouldn't be appropriate for CTPA? Kind of like three big ones. So renal issues, right? To just seasonal allergies. Yeah, to the contrast dye specifically. And what's that third one? Pregnancy. That would be when we do the VQ scan, right? So CTA, CTPA is always going to be your test of choice for this. Very sensitive. VQ scan for those three that we talked about. Venous ultrasound, right? We'll show you guys how to do that, where you trace their legs and you come down to rule out a DVT. Another appropriate one, you can do that bedside in the ER or the clinic, that POCUS, point of care ultrasound. Rarely performed, right? I don't really have a great reason why you would do these. Maybe it's like a research institute or a teaching hospital, they have it, they just want to use it. Sure, but it's not going to be a standard of care. They don't really have these readily available anywhere. MRIs usually take significantly longer than a CT as well. So what kind of diseases would a chest x-ray rule out for a patient that's dyspneic, tachypneic, have issues? Talk about one, pneumothorax, what else could it rule out?
Take hard.
Is that paramegaly? Maybe a foreign body obstruction? If you got a foreign body obstruction, you can see that chest x-ray. Yeah, maybe broken ribs, some diaphragm injury, something like that. You may find these non-specific. The two findings that would be found on a chest x-ray that would point you towards a PE, but I still wouldn't use it. I would still probably use me, get a CT. It's going to be this Hampton's hump, Westmark sign, Hampton's hump. It's going to be very distinct when you see it on the x-ray, but it's basically increased bleeding, and then where that lung tissue, that lobe, that's not getting blooding, it's starting to infarct, right? So again, it's a late finding. Westmark sign is going to be the dilation of the pulmonary vasculature. It's very difficult to visualize. Never seen one in real life. You've seen them in slides because nobody really ever diagnoses off those. In standard of care in America, we get CTAs. Here's what we're saying. So what lung is this?
Right lung.
So how would you describe this? If you got this chest x-ray and you're trying to describe it to somebody over the phone. So is it opaque? Is it translucent?
Single page,
Opacity
middle lobe.
of the right lower lobe probably be about as far as I would go. Right? Describing that. But what you're starting to see is that lobe is actually starting to infarct and increase bleeding. So here's Hampton's hump. You're going to see it on the lateral view. That's where that lobe is actually having issues right there. Again, this is a late findings you're seeing this. Westmark sign, can you guys even see this on the chest x-ray? So it's actually where you're losing the lung fields, and it clears up. It's this area right here. You can see very clear that it kind of darkens up right in there. So the arrow is not pointing in a great, but it's actually this right here. You kind of see it come out here, clear. So that would be that sign on chest x-ray. But again, your CTPA or CTA is going to be your study of choice. Takes just a second. They give them an IV, give them the dye, and they move them in there. May miss those very small and blind peripheral vessels. Typically, those are less concerning anyways. Those patients are going to be less symptomatic and less risk for the thing. We're talking more about the larger portions of the vasculature that's going to be at a higher risk. And then the VQ scan. Talked about that pulmonary one. Again, those three patients, renal disease, contrast allergy, or pregnancy. So what are examples of renal disease? So, what would be some lab findings of kidney disease? Creatinine, what else? Where's some labs for kidneys? BUN, right? Anything else? Serum creatinine? Right, so the reason I bring that up is as you move along in medicine, you start moving along in exams and these courses, it's not gonna be clear cut, just like black or white, like this patient has kidney disease or renal disease, right? They're gonna start painting a picture for you. They have polycystic kidney disease, or they were told that they had cysts on their kidneys, or their B creatinine is elevated, right? You're gonna start seeing these clues in there that's pointing you towards renal disease. So you have to kind of understand that it's just not gonna be clear cut, this is renal disease. This is an example of a VQ scan. They look a little bit clearer in person, but they're not that clear. So this is the V, which is the what? Inhalation, right? So they inhale that gas, radioactive gas, affects their lungs. So PE is not really going to affect their respiratory system, right? They can still breathe in the same amount of air because we talked about the vasculature. We'll look down here. So you're seeing that this is not perfusing. So is that positive? Positive for PE, right? So what are these little lines right here indicating? Those are like the fissures. Those are the actual differentiating the lobes. So that's not telling you that there is not perfusing this whole area where there's nothing going on, just a little bit, maybe a little bit of blood's getting by, it's perfusing, but the rest of that is infarcting. So now here's the Wells criteria. I'm not going to provide this for you in tests, so know this. This is one of those things you're probably going to need to know for a lot of classes. You're going to need to know for the rest of your PA school career if you haven't already seen it and you memorized it. So if you look at it too, it kind of ties in with what triad? The triad, right? And when you're going through this, there's two ways. The traditional 3-tier, what we're going to do for our purposes, I just want you guys to know the 2-tier approach, right? Make it very clear. Is it likely or unlikely? As we go down, predisposing factors, previous VTE, right? If they had a previous VTE, unprovoked, they're most likely still on some type of prophylactic medication, or they're still on that. Maybe, yeah, I had a blood disorder, they gave me some meds, but I didn't like going in for the lab, so I stopped taking it, right? That may be the history that you get for a patient, pointing in that they had a previous VTE. Recent surgery or mobilization, right? I'm not as concerned if they say, hey, I had LASIK or PRK done on my eyes, more so something that was an actual surgery where they got anesthesia, they were knocked out, and they were put in, maybe admitted to the hospital, more so along those lines. Do they have cancer, or do they have a history of cancer? When I say history of cancer, maybe that cancer is returning, and this is the first clue that that cancer is no longer in remission, that it's returning as a PD. Symptoms, are they having coughing up with blood, right? What else could that be?
Bronchitis.
What be the, what's that?
TB.
TB. All right. Heart rate, we already talked about that. Tachypnea, tachycardia, right? Very concerning. So if it's higher than 100, you're going to add those points up. Clinical signs of DVT, and what were those clinical signs of DVT? DVT. What were the clinical signs of that?
That's swelling.
Erythema, swelling, right? They can't flex the leg. There's a lot of pain. It was a very quick, acute process. They get DVT. The one I never liked is the clinical judgment. If I'm doing a Wells criteria, I probably already have concern that they're having a PE, right? So if they're matched up that Verko's triad and you have a high concern, you can do a 3 for there too, right? So if it's a high likelihood in your mind, that clinical judgment. Add those up. If it's 4, you're going to go to this flow chart, right? So we've assessed that we think our patient has PE. We do Wells criteria. If it's less than 4, PE is unlikely, but we're going to continue going down. Higher than 4, it's likely. So unlikely, or it's a low risk, we're going to go ahead and get that D dimer, right? So the reason we get that test, it's not good for confirming it, but it's good for ruling it out, right? So if I have a negative D dimer, it's less than 0.5. It's very unlikely that they're having a PE or DVT right now. Higher than 0.5, increased risk of that. It's going up. But again, D dimer is not going to tell me specifically if they're having a PE. It's just telling me that they're having some condition that's causing that. Could be PE. In that case, I'm going to go down here. Test choice is going to be CTPA or CTA. And then what would be those 3 patients that couldn't do a CTA? Renal disease, pregnancy, and what else? Not allergies, but yeah, allergic to that contrast type, very specific, right? Patient tells you they have seasonal allergies, that don't count. So we go down here, and it's PE or not PE, treatment or non-treatment. High likelihood, we're gonna skip the D-dimers because it's most likely gonna be elevated. We're gonna go straight to that CTE or that CTA or CTPA. It's just like a heart attack, thymus tissue. This is not something we can sit on. We need to treat it sooner than later. In our treatment, so important measures, supplemental oxygen, right? Then we can start anticoagulation. If you're like in a rural hospital or something with delayed CT or delayed diagnostics and you have a high suspicion, very likely you may go ahead and start your treatment, right? So anticoagulations, we'll talk about those. But key to understand, does not do anything to the existing clot, it's stopping additional clots. And again, talk about stable patients. Stable versus unstable, right? What I want you for testing purposes to understand this is going to be stable patients, not unstable. If it's unstable, game plan changes and we're going to go down a different route. But for testing purposes, it's going to be stable patient. So, not going to stop that existing clot. As long as the patient's stable, we don't necessarily need to do anything for that. We're going to allow the actual body to break down that clot. If they're unstable, treatment plan changes. They may need to get that clot out of there so they can save tissue. If the patient's stable, we're not going to do anything about the existing clot. We're going to let the body take care of it. What we're going to come down here is we're going to start them on low molecular weight heparin as a bridge for warfarin or Coumadin, right? So I remember I was in Iraq and a contractor came up to me at our aid station. He's like, hey, where can I get Coumadin refill? I was like, wait, what? What's going on here? He's like, yeah, I need some Coumadin, which is, right, if he gets shot, what would happen? We got blown up. He was bleeding out. So he wasn't happy with me. He got sent home the next day to call his company. But you're going to see that just weird stuff. So you're going to start him on heparin. That Coumadin takes days because it has to flush out all the vitamin C and S, which take a number of days to get out. So in the meanwhile, we do the bridge with the heparin. Can we keep people on heparin indefinitely? Yes or no? Can we keep them on? Okay, I put them in a hospital. Can I keep them on indefinitely? So we don't want to keep them on indefinitely because as time goes on, you'll hear more about this in hematology, is they can get heparin-induced thrombocytopenia, right? So we use it temporarily, typically about 5 to 7 days, till that goal, that INR, is 2 to 3. Once it's 2 to 3, we're going to discontinue the heparin and just keep going with the warfarin Coumadin, right? It's kind of the classic treatment. Now what's going on and changing is the NOACs and the DOACs are becoming more popular because you don't need that bridge and you don't need to do INR checks. Patients are more compliant. The issue with that is what? They're just a lot more expensive. Coumadin warfarin is dirt cheap. The NOACs and the DOACs are more expensive. But require no warfarin overlap and no INR. So it may be more appropriate if they can't get to the hospital or you don't have the ability to routinely check the INR. This is unstable patients. Again, I'm not going to test you on this, but this is where it changes, right? If that clot is so big, they do thrombolytics, clot blister, to break down that clot, so we salvage that portion of the lung so it actually does, because if we wait too long, it's going to infarct, continue to put pressure on the heart, and kill them. Surgery is very rare, but if you ever look at it, some of the cases for these gnarly clots that they bring out of these patients. Significantly higher risk for major hemorrhage though. So if they also have coexisting like brain bleed or something like that, they may not be appropriate for this. The contraindications for fibrinolytic therapy, just so you know, you'll see this more as you go throughout. IPAP, you'll see this in your senior semester multiple times. You will need to know those later on. Again, there's that kind of low risk PE, submassive, and then that massive, right? How you would go. Additional measures, these IVC filters. So that's not going to be your decision. Most likely, it's going to be you're going to talk with interventional radiology or neurosurgery, or not neurosurgery, pulmonology, some other different specialists, determine if that's appropriate. Recommendations for that is a recurrent embolism despite anticoagulation, they're just not responding. Typically at this point, if they're still not responding, they're under the care of hematology and they're not under primary care or ER or anything like that. Recurrent embolisms, pulmonary hypertension, or they have a reason why they can't be on anticoagulants. Maybe they have some underlying hematological disorder that put that on there to kill them. But these filters, they don't necessarily, not all filters are going to clench the clot. Some of the filters are designed to basically break that clot up into smaller, more manageable pieces, if that makes sense. But they have to be removed eventually. So again, a lot to consider with these. Patients may not be able to get that procedure done at this time. And then surgical removal of the PE, very, very unlikely that they're going to do that. Absolute emergency. There was a few cases, Iraq and Afghanistan, and surgeons having to do this because they just didn't have any other, and it wasn't really realistic to do fibrinolytics in a combat zone. They weren't able to do filters either. Now moving on to pulmonary hypertension or pulmonal. So this is kind of that secondary, what we were talking about. Mean arterial pressure, 25, right? Right heart catheterization is definitive diagnosis. So you feed that in, then it goes into the right ventricle. It's going to keep continuous monitoring up on the monitor in the patient's room. Greater 50% cases are idiopathic, right? So that's your group 1. Down here, as we classify these, pulmonary arterial hypertension is idiopathic. We don't have a great underlying cause. Or that's not the most common. Number 2 is going to be your most common, your left-sided heart disease, right? Specifically congestive heart failure, right? The pump is no longer working, so fluid is backing up, causing pulmonary hypertension. Chronic lung diseases, talked about that with ILD. Those other things, if it starts to calcify, it starts to fibrosis, it's going to start putting pressure on that, causing that. If they have coughing fits, putting pressure on the pulmonary vasculature, which is going to increase their pulmonary hypertension. Chronic thrombolytic disease, so those VTEs, PEs, or tumors, chronically they have multiple of them. They keep getting them, they're not responding to treatment. And then others, sarcoidosis or multifactorial, very generic. So, new or worsening dyspnea, right? Could we see pulmonary hypertension with a PE? Yeah. So PE could cause that pulmonary hypertension. So that's another thing that if you don't treat sooner than later, it may kill the patient because it's putting stress on the heart as well. Fatigue plus history associated with medical illness without associated with that. That's the GBP. Studies, right? Again, back to that, look for signs of right heart enlargement. So could we see that possibly on chest x-ray? Yeah, maybe able to see that on an echo of the heart too as well, CT, a number of things. What are some signs of right heart enlargement or pulmonary congestion? Peripheral edema, fluid backing up, what else? Dyspnea. JVD, right? Treatment is going to be the underlying cause, right? There's not really a great way to necessarily just tackle pulmonary hypertension. We're going to try to figure out what is the underlying cause and treat for those. So whether that's anticoagulants because they have a clot, digitalis get fluid off, right? Fix their heart, drugs and vasodilators. But untreated pulmonary hypertension or elevated pulmonary pressure that doesn't get treated is going to be a survival rate 2 to 3 years. Danielle's room is hot. My office is like freezing. I got a heater underneath my desk. I'm wearing like 2 jackets. Still like snot's coming out my nose over here. I'm sweating like in a All right, core pulmonal, the pulmonary heart. So it's 2 points for you right there. You can tell if I ever eat spicy food, if my head just starts sweating and it just starts coming down everywhere. So refer to the resulting alteration in structure and function of the right ventricle, right? We've talked about that as fluid starts Accumulating in the chest, pulmonary vasculature changes, starts putting more strain on the right heart. Unstable PE, leading cause of death, right, is right heart failure. Cor pulmonale is from chronic conditions. Elevated JVP, right, putting pressure on the liver, so you start getting enlarged liver. Peripheral edema of the feet. Most common causes are going to be COPD. So smokers, emphysema, you're going to see this with. And 30% 5-year survival rate. So typically, if you're seeing this, they have a comorbidity and they're not doing great. They're not managing their health very well. And they have a lot of stuff going on. You're kind of putting out one fire, another fire pops up, or medication you gave for this fire is causing this fire to worsen. So it's a constant balancing act for these patients. All right, two final things we're going to talk about: pulmonary vasculitis. Those are both autoimmune, right? So Wegener's granulomatosis, right? The ANCA attack both renal and pulmonary tissue, can also attack other tissues, but classically these are the two most common that are going to be affected, so you'll hear more about these in nephrology, urology, but it's primarily going to affect the renal, and then you're going to get this necrotizing vasculitis impacting the pulmonary capillaries. Then unique findings that you're going to see for these that are hallmarks of this disorder. So what's going to happen after you guys haven't already started doing that, you're going to start looking at people in the grocery store and diagnosing them and seeing them behind lines. Like I was in line a few weeks ago and I was behind a guy, I was looking at his neck and I was like, that dude's got to get that shit checked out. But at the same point, I was like, I really don't want to get called into this guy's healthcare. So you're kind of sitting there and I'm like, should I say something? I didn't say anything, but I felt bad afterwards. But saddle nose deformity is very distinct and it's a hallmark of this. Strawberry gum gingivitis. This can also be associated with certain type of anemias and certain type of oncology disorders, bleeding disorders. So that's not as unique, but it's, you have saddle nose, strawberry gums, put them together. That could be. What about TPI skin rash? What else could that be? Is there like a heat rash? You get those like little red spots on your skin. There's a number of things that cause that TPI skin rash. Chest X-rays are going to show these nodules showing cavitation. It's unique. I'll show you a picture of those. This is going to be your diagnosis, ANCA, right? It's up here. That's what's attacking them. So you're going to test for ANCA, and that would be your diagnosis. If you're not patients, typically you're going to manage. You may manage them after they've already been evaluated by internal medicine or rheumatology, and then they're going to disposition them to you most likely on a TMARD or one of these other medications after they've been on oral steroids, but oral steroids are still treatment for them. As long as they're under care, they usually have a pretty good prognosis. There's that saddle nose deformity. Right? If you understand the saddle, like this is where you would sit if you're a little cowboy or cowgirl. Right? Then you see that strawberry gums. Right? So you kind of laugh about it. You guys go through these, and I get it. I was in your role, like you're sitting in like downstairs in the lab, and you're just like, this is the last thing I want to do. And you're like, yeah, man, palpating. You're doing that. You're looking at guns online, doing whatever. I see what you guys are doing. I was a student too, right? But these physical exam skills are really going to pay off later on in life, especially if you're deployed and you don't have any advanced imaging or anything like that, labs. You have to fall back to this stuff. So all it takes is one patient. You having a bad outcome, and the next thing you know, you're going to be checking everything. Every patient, they're like, my knee hurts. You're like, open up your mouth. You're going to be checking teeth, dentures, and everything. I'm telling you, it's just one patient to bite you in the butt, and it changes the your game plan for the rest of your career. And then it has these very unique right here. So if you get one of these, a lot of times radiology will call you. They'd be like, hey, there's a really cool chest X-ray finding. Do you mind if I use it? Blah, 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 or something like that. You don't see these very often. So there's granulomas that are cavitating, right? Very unique about this disorder. You see them in the lower lobes and the upper lobes over here. It also kind of reminds me of like, you know, you see the videos of like the people, like the drug mules, that swallowed like a bunch of them. They have like 100 of these in their intestines, full of cocaine or something. All right, final one, Goodpasture syndrome. Right, it attacks both renal and pulmonary tissue, just like the last one. Causes recurrent alveolar hemorrhage. Right, so with that, This are gonna be one of those patients where you're gonna see them coughing up blood. They're gonna be anemic because this is a chronic disorder. They're gonna have shortness of breath. They're not gonna be just sitting there talking to you. They're probably gonna be a very, they're acute phase. They're not gonna be doing good. Chest X-ray, you're gonna have non-specific bilateral infiltrates, right? That can be a number of things. This is gonna be our diagnosis, the positive anti-GBM, glomerular basement membrane antibody. So again, iron deficiency anemia, what would that look like on a CBC? So their MCV, right, their mean corpuscular volume is gonna be decreased, right? And then if you draw iron on them, their iron serum is gonna be decreased as well too. So IDA, what may happen in real life, you get one of these patients and they have nondescript symptoms. They may just say, I have a cough, fever, I'm not feeling so great, we'll run down. But they're not coughing up blood, they're not hypoxemic or anything like that. You run a CBC on them, get baseline labs, you run a urinalysis. They're like, oh, you got a little bit of blood in your urine, so you start chasing that down. You get a CBC, notice that they're having iron deficiency anemia, so you start going down that path. You start treating these things. Patient's not responding, they continue to worse. This is where you start going down your rabbit holes and you start finding those things, right? IDA is the most common type of anemia worldwide. So it could be a number of things that's causing that underlying. Typically, patients, you treat them, they get better. So maybe a tell sign is that you treat that iron deficiency anemia, you give them supplemental iron. You ensure that they're compliant, they're not getting better. That may be the first finding that you're seeing for this. But if you do positive anti-GBM, which you kind of have to be a maniac if you're in primary care and you start running these labs off every patient, right? They could be like, wait, what is that? Like the lab may call you back and be like, I've never even heard of that test, man. What are you drawing? But that's how you make the diagnosis for this patient. Your affirmed internal med, combined treatment, oral steroids, DMARDs, plasmapheresis to remove those antibodies to get them out of the blood. So that's not a quick procedure. That's going to have to require multiple treatments where they go get their blood filtered. If you don't treat it though, 78% recover without long-term renal damage if you are catching this early on and you have a high index of suspicion. If you don't, then they could have renal damage. All right, any questions? All right, if you have any questions, meet me on the hallway because it's too hot.